So I'm very proud that actually, I should say, we are very proud that we have just announced here at the EuroPCR in Paris the launch of a major investigation, which is the Master DAPT study. That is going to be a huge study of 4,300 patients. We are going to recruit patients globally, meaning everywhere in the world, apart from United States, which means Japan, Asia, Europe, Africa, and South America as well. And we are going to focus on a very specific patient population who are patients presenting at least one eye bleeding risk criterion. And actually, the unique feature of the study, apart from the size, apart from the fact that it's going to be a global study, is that we are going to focus for the first time on this neglected patient population in whom we have no guidance whatsoever with respect to optimal duration of DAPT. This is going to be a randomized study. It's going to be an investigator-initiated and conducted study, which is going to be made possible by an unrestricted grant from Terumo. What do you think, Peter? Am I doing something right or not?
It's totally right. I think we're doing the right thing, and we are not only looking at patients for with the optimal DAPT regimen after PCI, but also we are looking at what is the most optimal antiplatelet therapy with the patients that are already on oral anticoagulation. And I think you will agree with me that is a fast-growing population that we are encountered with in our daily practice. So what is the best treatment therapy for those patients that are already on oral anticoagulation and need to have a stent? What is the best for them? I think we are trying to solve that question as well.
And importantly, we are targeting actually the first patient already in November. We don't know whether we'll be able to do it, but we will work like hell to make it happen.
Well, the Ultimaster drug-eluting stent is one of the newest generation drug-eluting stents that are currently available. It's a thin strut cobalt chromium stent with a biodegradable polymer, which elutes in 3 to 4 months, and from which sirolimus, a very effective rapamycin analog, elutes. And we have done an OCT study with the Ultimaster study that was presented at the EuroPCR last year, in which we looked at strut coverage at 1 month, at 2 months, at 3 months in a very complex patient population. And we noted that with the Ultimaster stent, the strut coverage was already around about 86% at 1 month, and that gradually went up to 95% at 3 months. So that was more or less a good indication that I think we can abbreviate DAPT therapy with this new biodegradable polymer eluting stent.
So this is a great question, and let me elaborate a bit on the rationale. If you look historically, the way DAPT has been generated and developed in the field of interventional cardiology, that was really to prevent stent thrombosis. That led to a misconcept today that DAPT is there to protect the stent. Actually, what we have understood more and more in the last, I should say, 10 years of research, is that DAPT is a good regimen to protect the patient, irrespective whether the patient has or has not received a stent. So the rationale for focusing on HBR patients, because those patients being at HBR per se, cannot tolerate a long-term DAPT regimen. And that's why we are leveraging on this specific patient population to prove the concept that once you have a very good and safe stent on board, you can drop DAPT at 1 month. It would be probably not ethical to do the same study in patients who are not HBR features, if anything, because we know that this patient can take advantage of DAPT irrespective of stent thrombosis, yes or no. So the rationale is actually to take patients in whom there is no room for prolonging DAPT more and more, to see whether the stent can really be independent from the benefit of DAPT per se. That is the rationale for choosing HBR. So I think this study will be key again because we have no specific information with respect to DAPT duration. And in fact, if you look at the guidelines, there is really an unmet clinical need because the guidelines are saying you may want to shorten DAPT if the risk of bleeding is excessive. Nobody knows what risk of bleeding excessive means, actually. We lack a risk score to predict bleeding risk in this specific patient population. And this study will really test whether we can go as short as 1 month or we should stay more conservative in the range of 3, 4, 5, 6 months DAPT duration. I think that will be a key information we are looking forward to having this study.
I think that's totally right, and also what is in the guideline is more expert opinion. It's not based on real data so far, and actually we are trying to build up this data, which potentially will guide the guidelines to better depth duration therapy for our patients.
And also the rationale for using Ultimaster, I think, is extremely sound at this stage, because there is a widespread thinking that the polymer per se remaining there, or at least some polymer, may actually create a lot of safety issue. One key feature of the stent is that the polymer actually goes away quite quickly, and that could actually contribute to the safety of the stent. On top of this, we know that the performance in terms of TLR, instead of late loss of the stent, is exceptional. So probably we will be using a very effective as well as a very safe stent in this patient population to prove the concept that if for the patient-specific reason, the DAPT cannot be prolonged, by having this stent on board is extremely safe. That would be really unique to this study.
Well, this study is targeting at multiple patient subsets. It's not only patients that are not on oral anticoagulation, but also we enroll patients that are actually on oral anticoagulation or on novel new oral anticoagulation drugs. And that is quite unique, because those patient subsets, especially with patients on oral anticoagulation, are very badly researched in the past. And this patient population is actually growing. There are much more patients that will be on oral anticoagulation. And so it will be very interesting to see how abbreviated, or what kind of combination of DAPT together with the oral anticoagulation or the novel oral anticoagulation drugs will act.
So we will actually 3 primary endpoints, which we are planning to test in a sequential manner for purely methodological reasons, because otherwise the study would have been even bigger. Let me emphasize this point, which is very relevant. Actually, the study is targeting 4,300 patients, so it's going to be a huge study. And of course, this is probably the only DAPT study which is going to be global. It's going to include Japan, as well as Asia, Europe, and South America. We have never seen such a big study performed so far. So out of this 4,300 patient population who will be selected upon HBR features, as I was elaborating to before, we are going to test first a non-inferiority of NACE, which is a combination of ischemic and bleeding events. So basically the question that we'll be asking is whether by shortening the DAPT, the balance of ischemic and bleeding risk, which in a way will level off. And then if that will be met, we will test whether a pure ischemic composite endpoint, such as MACE, will be non-inferior in the short DAPT arm, and if these 2 endpoints will be met on a non-inferiority basis, we will really go forward and test the real endpoint, which we would like to meet, which basically is superiority on bleeding. That's a rationale for shortening DAPT in this specific patient population, actually.